anywhere. So these are my disclosures, nothing to disclose. So basically I will talk I will introduce the concept of embolization, thyroid artery embolization, multinodular goiter, and tell the technique and admin protocol. And we'll see that whatever literature is available for thyroid artery embolization, multinodular, and I will show you some cases. So multinodular goiter can present in all the states, either hypothyroidism, euthyroid, or patient can be hyperthyroid. So hypothyroid can be because of the iodine deficiency, which causes enlargement of the thyroid, and most of the patients are basically either multinodular goiter in the euthyroid state or in the form of toxic multinodular goiter, and the cause is idiopathic. So we know that now the benign thyroid nodules, the treatment indications if they are having compressive symptoms in the form of pressing the trachea, esophagus, causing dysphagia or respiratory distress, or patients can have cosmetic complaints. So treatment options are surgery in the form of hemithyroidectomy. Total thyroidectomy is the gold standard treatment at present, and it is the standard of care. But these surgical procedures have high complication rate in terms of recurrent laryngeal nerve palsy, transient hypocalcemia, and of course the main thing is a scar. And big thyroid nodules with retroesternal extension have high morbidity and associated with some mortality also. So for small nodules, ablation has become a minimally invasive, very safe and effective treatment, OPD procedure. But the problem is when these nodules have retroesternal extension, multiple nodules, very large nodules, they are difficult to ablate, requires multiple sessions, and it becomes less cost effective. And patient has to come many times for these procedures. So basically the thyroid artery embolization started first in the experimental studies in China in 1992 for animal studies, and the first case report of thyroidectomy by embolization was reported in 1994, where they embolized all the 4 arteries, and after that the thyroid artery embolization became popular for management of the toxic diffuse goiter. So these are the 2 main articles where people have used the thyroid artery embolization for Graves' disease, and they saw in both these studies that the volume reduction was also roughly about 30 to 50% in 6 months. So that created a concept of thyroid artery embolization, and you see a lot of articles related to the Graves' disease, the role of thyroid artery embolization in the Graves' disease. So thyroid artery embolization is done like any other embolization procedure, either from the femoral or radial, and you can choose the catheter according to the anatomy. For selective embolization, microcatheters, and the embolizing agents most commonly used is the PVA particles. If we see the thyroid vascular supply, there are 2 arteries, superior and inferior thyroid, on both the sides. The superior thyroid artery is a branch of external carotid artery, and the inferior thyroid artery is a branch of thyrocervical trunk. And there is also a thyroid hema artery that is seen in approximately 3 to 5% of the cases, that arises from the brachiocephalic trunk. So we have to target these arteries and selectively cannulate these arteries. So most of the time the upper part of the thyroid is supplied by the superior thyroid artery, and the inferior part of thyroid by inferior thyroid artery, and you can use the radial or the femoral approach. If we see the size of the particles, so the common concept that comes is we use the bigger particles, 300 to 500 in superior thyroid, because there are chances of communication between the ECA and ICA, so we prefer to use the larger particles in superior thyroid, and inferior thyroid artery we can use smaller particles. But few authors also think that in inferior thyroid artery, to prevent the hypocalcemia, the parathyroid embolization, we should use the bigger particles. But still it's a matter of debate. But the most common particles that I use is 350 to 500 microns particles. So choosing what arteries has to embolize, you have to see the anatomy based on the imaging, either ultrasound or CT. So let's say if it is a one-sided, let's say right-sided dominant nodule, so you have to embolize the right superior and the right inferior artery. If it is a multinodular goiter involving both the lobes, you have to choose, see on the imaging where the residual parenchyma is maximum. You have to save that artery, right? So you can embolize up to 3 artery, and most of the time the rest, one remaining artery is sufficient to keep the patient in the euthyroid status. So endpoint is classical of pruning of vessels with stagnation of flow with more than 6 cycles. And also I would suggest that use of cone beam CT in thyroid artery embolization is very important, so that you look for the collaterals and also to prevent the non-target embolization. We know there is a lot of collaterals between the EC and IC, and I have told you that there can be complications. So role of cone beam CT should be done in all of the patient. And of course the post-procedure management is also very important, because the medical therapy is required in these patients. When we embolize the thyroid parenchyma, it releases the causes the necrosis of the parenchyma and releases the thyroxine hormones. So we initially there will be some hyperthyroidism. To control the hyperthyroidism, we give the steroids, IV dexamethasone at the time immediately before the procedure. Also, we start the patient on the beta blocker in the form of Ciplaril 40 milligrams. So basically, this reduces the symptoms of hyperthyroidism, palpitation, etc. And antithyroid medicine in the form of neomerconazole 10 milligrams is also given. Antibiotics, it all depends on the institutional policy and of course the symptomatic. So on the day of the procedure, 8 milligram IV dexamethasone is given, and patient is given the oral medications for about 4 to 5 days in the tapering form of oral steroids. Beta blocker should be continued for a week, and we also give the neomerconazole antithyroid medicine for a week, and depending on the clinical status, after 1 week we stop these medications. And these patients are follow-up is done for the clinical follow-up the first week, and also the first, third, 6th, 12th and 18, 24 months. CT scan is usually done at 3 to 6 months. So the knowledge of these medicines is of importance, because patients suffer some type of symptoms of hyperthyroidism after that, and you should know how to control it. You can take the help of your endocrinologist also to make it treatment. So if we see the literature, this is the largest study, and this is the study we started. I started doing the thyroid artery embolization. I don't have a very big experience, but whatever I have started after reading this paper published in JMBIR in 2020. So they divided the patients into 2 groups. The group A was 20 patients where a single site dominant nodule was there, and Group B, 36 patients where it was a multinodular involving both the thyroid lobes. And they have seen that after embolization, in both the groups, either dominant or the multinodular, both have shown significant volume reduction in the thyroid, decrease in the retroexternal extension. Also the hyperthyroid score, because many of the patients were initially having toxic multinodular goiter. They become euthyroid after the embolization, and the dose they were taking of eldroxin decreased, or the drugs was completely stopped. And roughly volume reduction was average 69%, which is equivalent to ablation we see for small nodules also. So this is the first study which I have discussed. The complications are not very much. Hoarseness in 2 patients, which resolves after symptomatic treatment, and as I have told you, many of the patients become euthyroid after doing the thyroid artery embolization. This is another recently published article where they have used for single site solitary symptomatic large nodules using the transradial approach of they published their data in 2023. the 3 months volume reduction rate you can see ranging from 62 to 92%, and the visual analog score, the cosmetic score significantly improved after 3 months. And this is the they have used the 300 to 500 particles in cases, and you can see nothing much of major complications. And they have used in initial 2 cases the PV particles. Initially they used to put the coils, but they stopped later. So we have done in a hospital 6 cases where 5 cases were multinodular goiter and 1 was solitary big nodules on the right lobe. And we embolized 1 artery in 1 patient, so 2 or 3 arteries in rest of 5 of the patients. And you can see luckily we found 3 thyroidema artery in 6 of the cases. So total 18 arteries were embolized, and we have started about a year back. We have a follow-up of 3 to 9 months. Technical success was 100%. 1 patient, all of the patient had some hyperthyroidism feature, but 1 patient has significant clinical hyperthyroidism which required admission for 3 days, controlled by our endocrinologist, and 1 patient has transient memory loss which recovered spontaneously after 5 days. There was no mortality or permanent complications, and we also got the good results in the form of volume reduction, 46 months possibly because of the short-term follow-up. Just to show a case, this is a 66-year female with neck swelling for last many years. We have done the FNAC twice. The patient was euthyroid. You can see the big swelling in the neck, the multinodular goiter, and this is the angiograms. Can you play the first video top? So you can see the distribution of the vascular supply is varies. Like in this case, the inferior thyroid artery is supplying the predominant part, and very small part by the superior thyroid artery. And this is the post-embolization pruning of vessels in both the arteries. And this is pre-embolization image, and you can see the significant decrease in the appearance of the neck. The volume reduction was significant. Another case, young female with long-standing swelling in the neck, and you can see the big nodule, volume about 235 cc, and you can see the shifting of the trachea towards the left side. And these are the angiogram images. You can see the large blush of the thyroid gland. This is pre-embolization, and this is the superior thyroid artery which is supplying the thyroid nodule, and this is the post-embolization superior and the inferior thyroid arteries. So again, this is 1 month and 6 month reduction in the volume and the cosmetic score. So still safety of thyroid artery embolization is yet to be properly established. And so my conclusion is that if the nodule is just cervical, not very big, not more than 30, 35, 40 cc, then can use the ablation as compared to thyroid artery embolization. If it is very big, and you don't require more than 2 settings, I would say, then ablation. If it is more, you expecting more ablation, then possibly thyroid artery embolization. If there is a external extension, then possibly thyroid artery embolization is better. So we need further studies. Of course, it is how we are presently doing up to 3 arteries in multinodular goiter, but safety is yet to be established with larger studies. What should be the ideal size of the particles, who are the best candidates, and possibly liquid agents, role of embolic agents, and long-term results we also require. And we can also use it for toxic multinodular goiters. Still no comparison versus surgery versus embolization, but yes, possibly next few years possibly we'll get some data to support this. So thank you for your patience. Thank you.